Welcome to the Australian Dental Council Explainer podcast.
Right. And imagine a panicked parent just runs into your clinic, right?
Yeah, exactly. Holding a bloody, knocked out front tooth in like a dry tissue.
You have exactly 15 minutes. 15 minutes before the cells on that tooth root die forever.
So what do you do? I mean, we are looking at a diagnostic and clinical landscape today that is just incredibly high stakes.
High stakes and, frankly, totally unpredictable.
Exactly. So today, that is exactly our focus. And this deep dive is for you, whether you are an overseas-trained dentist, an ADC candidate, a dental student, or an Australian oral health therapist.
We are exploring, really, this massive pedagogical shift in dental education.
Yes, specifically analyzing the methodology behind Odell's clinical problem-solving in dentistry, right? So that's spanning the third, fourth, and the upcoming fifth editions.
Plus, we'll be heavily integrating those vital chronic condition management guidelines and the ADC communication task scenarios.
Which are huge. And just a quick note before we jump in, this content is purely educational and not a commercial endorsement.
So to start, the way clinical proficiency is evaluated has just undergone this tectonic shift.
Yeah, we are definitely no longer in the era of just regurgitating chapters from a textbook.
No, not at all, because thriving in daily practice and, honestly, passing those rigorous equivalency exams, it demands a complete mastery of case-based clinical reasoning.
Right.
It requires taking this passive library of academic theory you have in your head and actively reorganizing it to survive high-pressure clinical environments.
Okay, let's unpack this. Why the abandonment of the traditional didactic textbook format?
Well, because patients don't walk in with a chapter heading on their forehead.
Exactly. I mean, for decades, dental education was heavily siloed. You studied oral pathology on a Tuesday, restorative dentistry on a Thursday, and you were tested on them completely separately.
Which isn't reality. A patient sitting in the chair complaining of, pain on biting, they aren't telling you if they're an endodontic case, a periodontal case, or a restorative case.
They just know it hurts. So why is a text like Odell's completely scrambling that traditional structure?
Because the cognitive architecture of modern diagnosis, it requires the active simultaneous synthesis of multiple disciplines. Traditional education built this vast library in the clinician's brain,
Yeah.
but it didn't teach them how to find the right book when the library is literally on fire.
That's a great way to put it.
So Odell's pedagogy forces a structured approach, like meticulous history-taking, specific clinical examinations, and forming a robust differential diagnosis.
Specifically to mitigate those cognitive biases that happen when the brain is under stress.
Exactly.
I always think of premature closure, which is just a massive trap in these exams. It's like a detective at a crime scene.
Oh, that's a perfect analogy.
Yeah. They find a muddy footprint. They arrest the very first suspect whose shoe roughly matches the tread, and they completely fail to check anyone else's alibis.
Right, they lock in a diagnosis way before looking at the broader evidence.
And how does that play out in the clinic?
It happens daily. So a patient presents with a deep keratoconus lesion visible on a bike wing radiograph, right? And they complain of spontaneous pain.
The brain immediately just wants to scream irreversible pulpitis.
Exactly, and initiate root canal therapy right then and there. The case is closed in the clinician's mind.
Because it fits the obvious pattern.
But because they stopped investigating, they failed to, say, probe the periodontal pocket depths.
Oh, wow.
Yeah, so they miss a 9-millimeter pocket indicating a deep vertical root fracture.
Which completely changes everything.
Totally. The biological reality is that the tooth is hopeless. It requires extraction. But the clinician is about to start a futile, hour-long endodontic treatment because they fell victim to premature closure.
I want to push back on how we actually fix that, though. Because there is also availability bias, right? Where the brain latches on to whatever is freshest in its memory.
Oh, absolutely.
Like if I just treated 3 really complex trigeminal neuralgia cases this month, suddenly every patient with vague facial pain looks like a neurology case.
Even if it's just a simple TMJ disorder.
Exactly.
Yeah.
So how does working through Odell's multidisciplinary cases physically rewire the brain to avoid these specific traps?
Well, by enforcing a mandatory pause, Odell's scenarios present a cluster of symptoms, and crucially, they include red herrings.
Oh, right, to throw you off.
Yeah, a methodology forces the reader to physically write out a differential diagnosis, listing, 3 or 4 distinct possibilities before turning the page to see the treatment plan.
That builds a sort of neurological safety net.
Exactly. It trains the clinician to ask, what else could this biologically be, instead of just jumping to, what do I think this is?
We are talking about building the muscle memory of clinical reasoning here. But let's look at what happens when that cognitive architecture is under absolute fire.
Right.
Like when a patient is bleeding or in excruciating pain from trauma, that mental safety net doesn't just need to work, it needs to work in seconds.
And acute dental trauma is precisely where the rote memorization approach just totally collapses. It's also where ADC candidates often really struggle.
Because of the stress.
Yeah, and the physiological reality of the injury dictates a highly algorithmic, time-sensitive response. We can contrast two distinct scenarios from Odell here. Case 21, the displacement of an upper central incisor, and case 26, the complete avulsion of that incisor.
Okay, let's focus on the avulsion first. The tooth is completely out of the socket. The evidence-based protocols here are incredibly rigid and obviously for good reason.
It all comes down to the survival of the periodontal ligament, the PDL cells, right there on the root surface. The extraoral time is the single absolute predictor of success here. Those PDL cells are highly, highly sensitive.
So what's the window?
If the tooth is replanted within 15 to 30 minutes, the prognosis for those cells regenerating and reattaching is actually relatively high.
But after that?
Once you cross the 60-minute threshold, particularly if the tooth has been kept in a dry environment, those cells undergo irreversible necrosis. They die.
I need to stop you there because the storage medium is where a lot of public advice just goes totally wrong.
Oh, absolutely. It's a nightmare.
Right. If that parent calls the clinic, we tell them to pick it up by the crown to avoid crushing those surviving root cells. But if they can't shove it back into the socket themselves, they often ask if they should put it in water.
Which is the worst thing they could do.
Why is water an absolute disaster for an avulsed tooth?
Well, it is a matter of basic cellular osmosis. Tap water is a hypotonic environment.
Okay.
So the fluid inside the PDL cells has a higher concentration of solutes than the tap water outside. Osmosis forces that water rapidly across the semi-permeable cell membrane and right into the cell.
Causing it to swell up.
Exactly. It swells and ultimately leases or bursts. You have effectively destroyed the very cells you desperately need for reattachment.
So we need a physiological osmolarity.
Yeah.
I know Hank's balanced salt solution is the gold standard, but let's be real, nobody has that sitting in their kitchen.
No, of course not. So milk is the clinical fallback.
Because of the osmolarity.
Right. It has a compatible osmolarity and contains essential nutrients to keep those cells viable for a few critical hours until they get to you.
Okay, so once the patient is actually in the chair, the protocol is highly specific.
Very. You replant the tooth and apply a flexible splint for up to 2 weeks.
The flexibility is vital there, right?
Extremely vital. It allows for micromovement, which physiologically stimulates the surviving PDL cells.
And that prevents ankylosis.
Exactly. Ankylosis being when osteoclasts resorb the root and replace it directly with alveolar bone. You don't want that.
Right. And you also must prescribe systemic antibiotic prophylaxis, generally amoxicillin or doxycycline, depending on the patient's age, to manage that contaminated root surface.
Furthermore, because the pulpal blood supply has been entirely severed at the apex, endodontic therapy must be initiated within 7 to 10 days for teeth with closed apice.
To prevent inflammatory root resorption.
Spot on.
So compare that rigid protocol to case 21, the displaced tooth. Say it is a lateral luxation where the incisor is literally pushed backwards into the palate.
Right.
The tooth is still in the mouth, so we aren't fighting the extraoral clock in the exact same way, but the structural damage is entirely different.
The physiological reality of luxation is that the alveolar bone socket itself is actually fractured, and the neurovascular bundle at the apex is completely crushed.
So you are no longer just treating a torn ligament.
No, you are managing a bone fracture. Therefore, the splinting protocol changes entirely. You frequently require a flexible splint for 4 weeks, not 2, to allow the bony walls of the socket to heal properly.
Wow, okay. Let's move from the chaos of blunt trauma to the dread of unexpected postoperative complications.
The stuff of nightmares.
Truly. So here's a classic exam scenario. You are extracting an upper first molar. It's a really difficult extraction. The roots are divergent. And suddenly, you hear a hollow sound from the suction.
You've created an oroantral fistula, an OAF.
Yep. The maxillary sinus is now communicating directly with the oral cavity. Odell's case 18 covers this thoroughly, doesn't it?
It does. And diagnostic clarity is your immediate priority here. You'll actually observe bubbling of blood in the extraction socket that's synchronous with the patient's breathing.
And the patient might panic.
Yeah.
Right, reporting that air is rushing into their mouth or that the water they try to rinse with is coming straight out of their nose.
Exactly. It's incredibly distressing for them.
But I want to inject some clinical reality here. It is one thing to sit in an exam hall and just list the textbook surgical options for an OAF.
Right.
But when the patient is actively panicking in the chair and you are staring at a hole into their sinus, how do we decide in real time between localized triage versus stopping everything to raise a buccal advancement flap for immediate surgical closure?
Well, what's fascinating here is that the physiology of the sinus actually dictates your timeline.
How so?
You cannot, and honestly should not, perform a definitive surgical flap closure if the sinus is already actively infected, or if you lack the specialized equipment, or if the patient is just psychologically unable to tolerate an extended surgical procedure right then.
So immediate triage is the ethically and clinically sound choice for a small to moderate communication.
Yes, which means stabilization. We want to encourage a robust blood clot.
So we place a figure-of-8 suture over the socket to secure a hemostatic sponge, physically blocking the communication.
Precisely. And we prescribe antibiotics to prevent sinusitis. Plus, critically, nasal decongestants like ephedrine drops.
To keep the sinus ostium open, preventing pressure buildup inside.
Exactly. We also have to give strict sinus precautions, so no blowing the nose, no drinking through a straw.
Right. And then the definitive surgical closure of a persistent epithelialized fistula is just planned for a later date when the tissue is much healthier.
Now, contrast the immediacy of an OAF with the delayed misery of a dry socket, or alveolar osteitis, which is heavily tested in the ADC tasks.
Oh, definitely. This usually presents 3 to 5 days post-extraction.
Yes.
And it is absolutely vital to understand that a dry socket is not an infection. I see candidates confuse this constantly and try to immediately prescribe antibiotics.
Which is completely wrong. It is a failure of the healing process, specifically fibrinolysis.
Can you break down that biological mechanism?
Sure. After an extraction, a blood clot forms naturally. In a dry socket, tissue kinases are released due to surgical trauma or bacterial pyrogens.
Okay.
These kinases activate plasminogen into plasmin, and that plasmin aggressively dissolves the fibrin in the blood clot before the granulation tissue can even organize.
So the clot simply washes away.
Right, leaving bare alveolar bone totally exposed to the oral environment.
Which is excruciating.
Yeah.
And this is why it is overwhelmingly more common in the mandibular molar region, isn't it?
Yeah.
Because the bone is highly dense and the blood supply is far less robust than in the maxilla.
Exactly. So the clinical protocol here is palliative. It's not curative.
We absolutely do not curette the socket, right? I mean, scraping bare inflamed bone only causes extreme pain and introduces bacteria deeper into the marrow.
You never scrape it. We gently irrigate with warm saline or chlorhexidine, just to remove food debris. Then, we place an abundant dressing, like Alvogel.
I want to highlight the mechanism there because the active ingredient in Alvogel is eugenol.
Yes, which acts directly on the exposed nerve endings in the bone to drastically reduce pain transmission.
Okay, we have spent considerable time on acute emergencies, where seconds and days really matter, but the clinical muscles required for acute care are entirely different from those needed for chronic condition management.
Completely different. Chronic care requires stepping away from that algorithmic triage and adopting a mindset of continuous long-term monitoring.
You are managing diseases that essentially hide and progress silently over years.
Right. We see this every single day with gingival recession, which Odell covers in Case 4.
A patient comes in terrified because their teeth literally look longer, or they have this sharp, zinging sensitivity when they drink cold water.
And the management here is highly layered. Your first intervention has to be psychological.
Reassurance.
Yes, you must educate the patient that while gingival recession is biologically irreversible-like, the lost attachment will not spontaneously regenerate. It is not inherently progressive if the etiology is properly managed.
But I am struggling to see how we manage the etiology without just telling the patient to brush softer.
Well, the guidelines dictate active monitoring, which means study casts or high-resolution clinical photography or precise periodontal probing depths recorded at regular intervals.
But what about the hypersensitivity? I mean, why does a recessed gum cause such severe pain from just a cold drink?
It comes down to the hydrodynamic theory of pain.
Which is crucial to understand.
Very. When the gum recedes, it exposes the root surface, which is made of dentine. Dentine is porous. It's filled with thousands of microscopic dentinal tubules that run directly from the root surface to the pulp where the nerve resides.
And inside these tubules is fluid.
Exactly. When a cold stimulus hits the root, that fluid physically contracts and moves outward. This rapid fluid shift pulls on the odontoblast processes right near the nerve, triggering a sharp shooting pain.
Ah, so our treatment must physically block those tubes.
Right. We use high fluoride varnishes or desensitizing toothpastes containing compounds like stannous fluoride or arginine, which actually precipitate into the tubules and literally plug them.
Or we use potassium nitrate, which chemically depolarizes the nerve so it just cannot fire.
Yes, but we also have to look at the structural damage. Exposed dentine is far softer than enamel.
Making it highly susceptible to non-carious cervical lesions, like abrasion from aggressive brushing or erosion from their diet.
Diet analysis is mandatory here. You are investigating the titratable acidity of their daily intake.
Like hidden acids in health foods.
Yeah, kombucha or frequent sipping of lemon water. That can rapidly dissolve exposed root dentine. You are mapping their habits over years, not days.
Let's transition from what we can see to what is completely hidden. Odell's case 2 focuses on a terrifying moment for any clinician: radiographic pathology.
Oh, absolutely.
You take a routine panoramic X-ray, and you see a massive multilocular radiolucency. Just a dark soap bubble or honeycomb-like lesion expanding right through the mandible.
The differential diagnosis for a multilocular radiolucency requires an immediate pivot from general dentistry right into oral pathology and maxillofacial surgery.
What are we looking for?
You must consider odontogenic keratocysts, or OKCs, which are notorious for a high recurrence rate because they have these thin, friable epithelial linings.
And they often form satellite daughter cysts deep in the
Right.
cancellous bone, right?
Exactly. You must also consider ameloblastomas, which are benign but locally highly aggressive. They expand the cortical plates and cause severe facial deformity if left unchecked.
This is where the standard of care has drastically shifted, though. A two-dimensional panoramic film is legally and clinically insufficient for managing this now.
Completely insufficient. We must utilize a cone beam computed tomography scan, a CBCT.
Because we need a precise three-dimensional map.
Yes, to see if the lesion has resorbed the adjacent tooth roots, if it has perforated the lingual cortical plate, and specifically to trace its exact proximity to the inferior alveolar nerve canal.
Right. Moving from hard tissue pathology to soft tissue, Odell's case 45 explores oral medicine with the presentation of a white patch, or leukoplakia, on the lateral border of the tongue in a 52-year-old woman.
This is the classic red flag scenario.
I see this constantly.
Yeah.
Usually it is frictional keratosis, right?
Yeah.
Like a sharp, broken cusp of a lower molar has been traumatizing the tongue tissue, and the body just builds up a protective layer of keratin, almost like a callus on a foot.
Yes.
But at what point does a clinician look at a white patch and think, I need to biopsy this immediately?
The timeline is your primary diagnostic tool here. If you identify a traumatic cause, say you smooth down that sharp fractured cusp, you observe the lesion.
For how long?
If the white patch does not completely resolve within exactly 2 weeks, the etiology is not purely frictional.
Period.
Period. The protocol dictates an urgent referral for an incisional biopsy. You are legally and ethically obligated to rule out epithelial dysplasia, which are pre-cancerous cellular changes.
Or an established squamous cell carcinoma.
Exactly.
And when managing these chronic complex patients, we inevitably run into systemic medical management, which is the focus of Odell's case 44, anticoagulation.
This is a very common stressor.
You have a patient needing an extraction,
Right.
but they are taking warfarin for a prosthetic heart valve, or perhaps one of the direct oral anticoagulants, the DOACs, like apixaban.
The clinician is really trapped between 2 severe risks here. If you advise the patient to stop their anticoagulant, you risk a fatal thromboembolic event, like a stroke.
Right.
But if you extract the tooth while they are fully anticoagulated, you face the risk of catastrophic, unmanageable post-operative hemorrhage.
So the management requires a really deep understanding of the clotting cascades. Warfarin affects the vitamin K-dependent factors, and its efficacy is measured by the INR.
Yes. The current guidelines, such as those in the British National Formulary, usually permit simple extractions if the INR is below 4.0, checked ideally within 24 hours of the procedure.
But DOACs are entirely different.
Totally different. They target specific factors in the cascade, like factor Z or thrombin directly.
And there is no routine blood test, like an INR, to measure their precise effect on the day, is there?
There isn't, which means your local hemostatic measures must be flawless.
What does that look like?
You utilize oxidized regenerated cellulose in the socket, which acts as a physical matrix for clot formation. You use tight figure-of-8 sutures to apply direct mechanical pressure to the underlying bone.
Furthermore, this case underscores a huge ethical reality. The guidelines for anticoagulants evolve rapidly.
Very rapidly.
And medico-legally, ignorance of the current protocols is not a defense.
Yeah.
You are bound by duty to maintain your pharmacological knowledge.
Okay.
So what does this all mean for the patient experience? We have just detailed aggressive pathologies, cancer risks, and fatal bleeding scenarios.
It's a lot.
How do we balance this intense clinical reality with the actual human being sitting in the chair who is terrified?
Well, if we connect this to the bigger picture, the very act of thorough, meticulous investigation is actually a therapeutic communication tool.
How so?
When you take the time to map out a lesion on a CBCT, or when you take high-resolution photos of their gingival recession and literally sit down to explain the hydrodynamic theory of pain to them, you are proving that their condition is being actively managed.
You're transforming from just a distant diagnostician into a long-term clinical partner.
Exactly.
That partnership is tested the hardest when clinical science collides with human belief systems, which brings us to the most heavily scrutinized area of the ADC exams, the communication tasks and ethical dilemmas.
This is where so many candidates fail because technical knowledge alone is no longer enough.
Consider the classic ADC scenario regarding amalgam replacement.
Yeah.
A patient requests the immediate extraction of 20 clinically sound 20-year-old silver amalgam fillings.
Why?
Because a naturopath told them the mercury is causing their chronic fatigue syndrome.
Ah, yes.
Here's where it gets really interesting. A patient demands an invasive, irreversible treatment based on outside advice that directly contradicts our evidence base.
Right.
How do you sternly stand by the biological science without being arrogant or dismissing their genuine health anxieties?
The protocol requires absolute neutrality regarding that third party. You do not disparage the naturopath.
That's key.
Instead, you focus the conversation entirely on the biological cost to the tooth itself. You explain the evidence. The process of applying a high-speed grill to an old amalgam restoration generates heat and friction that actually releases significantly more mercury vapor than just leaving the stable filling untouched.
But it is more than just vapor. I always explain the trauma to the odontoblast.
Yes, the structural damage.
Every single time a tooth is re-drilled, you are physically severing the dentinal tubules closer and closer to the pulp chamber. You are subjecting the nerve to severe structural and thermal trauma.
Massively increasing the risk that the tooth will require a root canal in the near future.
Right. You are trading a perceived systemic risk for a guaranteed localized trauma.
Exactly. And you must document this conversation exhaustively in the clinical notes.
What should the notes actually say?
Medico-legally, your notes must state: discuss the lack of evidence supporting prophylactic replacement of sound amalgams for systemic health. Advise patient of the biological cost of reintervention, including pulpal trauma and loss of structural integrity. Patient understands risks.
Okay, what if they pivot? What if they say, fine, I understand the science, but they look terrible when I smile and I just want them gone?
Then you transition to negotiating patient autonomy versus non-maleficence.
Do no harm.
Right. If aesthetics are the overriding informed concern, you propose a compromise. You suggest replacing only the restorations in the highly visible smile line, perhaps just the upper premolars.
So you minimize the intervention while addressing their primary aesthetic complaint.
Precisely.
Let's look at another communication minefield. The cracked cusp. A 45-year-old patient presents for a routine checkup. They point to tooth 46, a lower right first molar with a massive old amalgam, and say they get a sharp shooting pain when chewing nuts or seeds.
The clinical examination is highly specific here. The tooth might not be tender to lateral percussion at all.
But when you use a diagnostic instrument like a tooth sleuth or a frac finder,
Yes, placing it on one specific cusp and asking them to bite down hard, the pain doesn't actually occur on the bite. It occurs precisely when they release the pressure.
we are back to the hydrodynamic theory. The physical pressure of the bite wedges the microscopic crack open, fluid rushes in, and upon release, the crack snaps shut.
The fluid shifts violently and the nerve fires.
But a crack almost never shows up on an X-ray unless the tooth is literally completely split in half. So how do you communicate a diagnosis that the patient cannot see and that the X-ray cannot prove?
You manage expectations from the very first sentence. You explain the mechanical reality of the crack, and you emphasize that treatment is unpredictable.
What's the diagnostic step?
You explain that removing the old filling and placing an orthodontic band around the tooth to hold it together under tension is a diagnostic step. If the pain resolves, the crack is likely superficial and a full coverage crown is indicated.
And if it doesn't?
If the pain persists, the crack has invaded the pulp and endodontic therapy is required. And if the crack extends down the root, below the alveolar bone crest, the tooth is entirely hopeless and must be extracted.
You must outline the worst-case scenario before you ever pick up a drill.
Always.
And when the worst-case scenario is our fault, we enter the realm of the duty of candor, highlighted in Odell's cases 30 and 71.
These cases are titled, "Whose Fault Is It This Time?" which is a visceral reality check.
You are performing a complex endodontic treatment. You are instrumenting a curved mesiobuccal canal, and you feel a click. A rotary file has separated and is broken off deep inside the root.
The legal and ethical obligation here is immediate transparency.
Immediate.
The duty of candor means you cannot wait for the patient to complain, and you cannot hope they won't notice on the post-operative radiograph. You must stop the procedure, sit the patient up, and explain the complication using plain, non-jargon language.
But candidates often freeze here because they confuse an apology with an admission of legal liability.
Which is a huge mistake.
What is the specific phrasing we use to be honest without inviting a lawsuit?
You express empathy without accepting negligence.
Okay, like what?
You state, during the procedure, a very fine instrument we use to clean the root canal separated, and a small piece remains inside the tooth. This is a known risk of this complex procedure due to the severe curvature of your root.
So you establish it as a known risk, not negligence.
Right. Then you say, I am very sorry this complication has occurred. Here are the immediate steps we are taking. I have stabilized the tooth, and I am referring you to an endodontic specialist who has the microscopic equipment required to attempt retrieval. My practice will cover the cost of this specialist consultation.
You outline the facts, you apologize for the distress, and you immediately offer a concrete solution.
Exactly.
Let's pivot to a scenario where the ethical dilemma isn't an error, but an observation. Safeguarding, covered in Odell's case 36, skateboarding accident.
A very heavy case.
A parent brings in a non-ambulatory infant with a torn upper labial frenum and a fractured incisor. The parent is super vague, claiming the child tripped over a toy.
This tests your ability to recognize the forensic anatomy of non-accidental injury. A torn labial frenum in an infant who cannot yet walk is an immense, glaring red flag.
What does it usually indicate?
It typically indicates that a bottle or a pacifier was forcefully jammed into the child's mouth.
We're trained to look at the teeth, but in this scenario, you have to look at the entire dynamic.
Absolutely. Is the parent hostile or overly defensive? Is the child withdrawn? Are there bruises on the neck or behind the ears?
Which are classic signs of abuse, unlike bruises on the shins or elbows, which are typical of normal play.
As a clinician, you are a mandatory reporter.
Your clinical notes become forensic documents here. You must objectively record the size, shape, and color of the laceration. You do not write, parent abused child.
No, never. You write, clinical presentation of torn frenum is inconsistent with the provided history of a fall from a standing height.
You must know your local child protection protocols and initiate a report immediately. The ethical burden is entirely on you to protect the vulnerable patient.
And regarding vulnerability, the upcoming 5th edition of Odell places a massive emphasis on team dynamics and conflict resolution.
Which is interesting. Why is a textbook on clinical diagnostics focusing on arguments between the dentist and the dental assistant?
Because the data from healthcare research, largely adopted from the aviation industry's Swiss cheese model of errors, proves that hierarchy-related poor communication is a leading cause of catastrophic clinical mistakes.
Give us an example.
Imagine you are preparing to inject a local anesthetic. You are tired, and you inadvertently pick up an articaine syringe meant for an adult, but you are treating a 15-kilogram child. Your dental nurse notices the error.
But if the clinic culture is intensely hierarchical and you've previously snapped at that nurse for questioning your authority, they will remain silent.
Exactly. The error reaches the patient because the communication pathway was blocked by ego.
Synthesizing the principle of non-maleficence, do no harm, requires a cohesive, psychologically safe team environment where any member, regardless of their title, can halt a procedure if they identify a risk.
Clear, respectful communication prevents errors long before the needle touches the tissue.
We have dissected the cognitive frameworks, We have managed acute bleeding and chronic silent diseases, and we have navigated the incredibly complex ethical minefields of clinical practice.
We've covered a lot.
Now, let's look at how the foundational rules we just discussed are being rewritten by emerging technology, which really dominates the latter half of Odell's fourth and fifth editions.
The overarching philosophy of modern dentistry is minimum intervention. We are finally moving away from the era of aggressive extension for prevention drilling.
And digital tools are making this philosophy a clinical reality.
Yes. We are seeing the deep integration of CAD/CAM technology, computer-aided design, and manufacturing. We can now prepare a tooth with minimal reduction, optically scan it, and mill a highly precise ceramic restoration in the office on the same day.
We mentioned CBCT earlier, which has fundamentally changed our spatial understanding of anatomy. But the true paradigm shift, the technology that is rewriting the diagnostic process itself, is the integration of artificial intelligence and assisted intelligence into radiographic interpretation.
The AI algorithms currently being deployed are built on convolutional neural networks trained on literally millions of annotated dental radiographs.
They analyze pixel density at a level human eyes just cannot perceive.
They can highlight early interproximal caries that a fatigued clinician reviewing their 40th bite wing of the day at 4 p.m. on a Friday might easily miss.
And they can quantify alveolar bone loss down to fractions of a millimeter.
Yes.
I want to push back on what this means for the profession, though. If AI is going to consistently outperform human vision in spotting the subtle radiolucency or the hidden cavity, is the dentist's role going to fundamentally degrade?
That's the fear, isn't it?
Yeah, are we shifting from being the primary diagnostician to merely being a treatment coordinator or a surgical technician who just executes what the computer tells us to do?
Well, if we connect this to the bigger picture, we have to recognize what AI truly is, and critically, what it completely lacks.
Which is?
AI is an exceptional tool for technical pattern recognition. It is faster and more consistent at identifying grayscale anomalies, but AI possesses zero empathy.
Right.
It has no ethical framework. It entirely lacks the holistic, contextual understanding of the human condition.
An AI can scan a bite wing and perfectly outline a deep calcareous lesion on a second molar, flagging it for a root canal.
Sure.
But that AI cannot look at the patient sitting in the chair. An 85-year-old with advancing dementia, severe physical frailty, and profound dental anxiety, and understand that subjecting them to a stressful 90-minute endodontic procedure is fundamentally cruel.
That is exactly the limitation. Complex care planning is a uniquely human synthesis. You have to weigh the technical, pixel-perfect findings against the patient's financial constraints, their manual dexterity to clean a complex restoration, and their overall life expectancy.
A palliative approach or a simple extraction might be the most humane and ethical choice, even if the AI recommends sieving the tooth.
AI provides the raw data points. The human clinician provides the wisdom to use them ethically.
And that wisdom is going to be tested heavily as our patient demographics shift. Odell's fifth introduction highlights the complex restorative management of the older adult, dealing with polypharmacy, dry mouth, and failing dentition.
And, of course, the massive incoming wave of peri-implantitis.
Yes, we have spent 20 years placing millions of titanium implants. Now we are dealing with the biological fallout.
Aggressive bacterial biofilms attaching to the rough titanium oxide surfaces, causing massive macrophage responses and destroying the surrounding bone.
Managing those failing implants, communicating the failure to the patient, and navigating the surgical retreatments will be the daily reality for the next generation of clinicians.
It's going to be a massive challenge.
So what does this all mean? We have covered an immense amount of ground today. Let's distill the core takeaways.
Let's do it.
We explored the evolution from rote memorization to active, dynamic clinical reasoning, learning how to build cognitive safety nets against premature closure. We dissected the rigid physiological protocols for acute trauma and contrasted them with the meticulous long-term monitoring required for chronic diseases.
We also detailed the absolute necessity of ethical transparency.
Concepts like the duty of candor.
Right, and managing demanding patients without compromising biological science, and understanding the forensic implications of safeguarding. These are not soft skills. They are the rigid framework of professional survival.
This raises an important final question. As AI and digital tools inevitably perfect the technical aspects of identifying pathology, as the software becomes undeniably better at reading the X-ray than we are, will future equivalency exams and clinical practice itself evolve?
What do you mean?
When we reach a point where we are evaluated far less on what we can see on the screen
Mm.
and almost entirely on how we communicate those findings, negotiate the ethical compromises, and manage the profound, messy reality of the human being sitting in the dental chair.
The clinical landscape is changing rapidly, but the core of the profession remains absolutely human. It has to.
It is a fascinating horizon for the field. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.